So we'll start with some of the joints of the axial skeleton. We'll talk about the TMJ or Temporomandibular Joint, as well as your intervertebral articulations or joints. So our temporomandibular joints were basically where the mandible meets up with the temporal bone. Remember, we have one mandible, but there's two temporal bones. And so it's where the mandibular condyle meets the mandibular fossa of the temporal bone. And where the condyle meets the fossa, that's where those bones articulate or connect. Now, you're not going to find bone rubbing up against bone because it's a synovial joint. And there's some supporting cartilages in the synovial joints. We have like an articular disc. This articular disc you find in the TMJ is actually made of fibrocartilage. And what's interesting is that temporomandibular joint disorders correlate with psychological disorders. So what we find is that if for those individuals who have TMJ damage, they most likely suffer from some sort of anxiety disorder or depression. Because what do people do when they're anxious or depressed? You know, you might grind your teeth even during the day or at night, and that grinding of the teeth not only wears the teeth but also puts stress on your TMJ, and it ends up wearing out the joint as well. There's some supporting ligaments like the sphenomandibular, stylomandibular, and temporomandibular. These basically are just named for the bones that they connect to. And so this is what the joint looks like here, you guys. So you can see that it's supported by a lot of different ligaments here. Now, if you zoom inside the joint and cut away at those ligaments, you can see the structure of the synovial joint. So we got our articular capsule here. We got our synovial cavity, or joint cavity, and then within that we have an articular disc. It kind of makes sense, though, why you have an articular disc, right? Because if that articular disc weren't there and you chewed on something really hard, that means your bone would be pushing right up against the other bone, right? The mandible, the mandibular condyle, would be pushing up right against the mandibular fossa of your temporal bone. So it makes sense you want an articular disc here to help cushion that. So when you chew, you're actually chewing against this articular disc.
Is that,
it can wear down. No, it's fibro. So it's fibrocartilage. But if it wears down, it can sound like sand inside your joint. So if anyone complains of they hear like there's sand in their jaw, or if it sounds like there's like crackling or popping, or if sometimes you can actually hear a popping sound if that articular disc is loose, then that can suggest TMJ problems. But again, I should move back to you guys. It's important to note, though, that not everybody with a TMJ issue has a psychological issue. They have a tendency to correlate. Yeah. But they correlate. However, it is important to note, though, that like 1 in 5 Americans are clinically depressed. So 20% of Americans. Adults, I mean.
Are they all nursing students?
Actually, the lifetime risk for depression is 1 in 3. So 1 in 3 people will have depression in their lifetime. But typically people get over, it's more of a temporary condition, if that makes sense. So what about these intervertebral articulations? Well, you find these between your vertebrae, and you find an annulus fibrosus and a nucleus pulposus. And what does this look like? Well, here's an intervertebral disc. It's got an outer layer of hyaline cartilage and an inner layer of kind of like a gelatinous type of material. And this, actually, let's say hyaline, I meant fibrocartilage. So it's an outer layer of fibrocartilage, and it's an inner layer of gelatinous material. So it helps basically cushion between these vertebrae really well. That way, when you're walking around, your vertebrae aren't just rubbing up against each other, and they're cushioned by this nice intervertebral disc. Now, there are also ligaments that you find that hold your vertebrae together. Otherwise they could just slide around. So we have supporting ligaments that help basically hold our vertebrae together, and you find these outside of the joint cavity. Now, some other joints of the upper limbs include like the sternoclavicular, acromioclavicular joints. These are where the clavicle attached to, right? So what 2 bones does the clavicle attach to? The sternum and the scapula. So the sternum and the scapula, right? So at the sternal end, what we find is the clavicle attaches with the sternum, right? And that's actually a synovial joint, so it's freely movable. At the acromial end, the clavicle attaches with the acromion process again on the scapula. That's also a synovial joint, which is interesting. Now, the glenohumeral joint, right? Glenoid cavities in the scapula, humerus. So the glenohumeral joint's your shoulder joint. Elbow joint we'll talk about in terms of the ulna and your humerus, and the radiocarpal or wrist joint we'll talk about as well. So the sternoclavicular joint, it's basically this diarthrotic saddle joint that you find between the sternum and the clavicle. It's a synovial joint, so it's more highly movable, and it's supported by different ligaments that you find nearby. Ligaments are just named for what they attach to. So you can see here where the clavicle meets the sternum, there's actually a synovial joint, so it's more movable. It kind of makes sense, right? Because the clavicle is what attaches to your scapula. It's your scapula that moves when you move your shoulder joint around, right? That's all part of the pectoral girdle. So what's interesting is that if you abduct your arms, you're actually also moving your clavicles. So your clavicles also move in that angle. Or if you adduct your arms, the clavicles also move back down to a resting position. Yeah. Yeah, like if you feel on your clavicle, you guys, and then adduct a lot, all of a sudden your clavicle kind of disappears, right? Where'd it go? Well, it's just kind of like, it kind of like went more superior. It's kind of interesting how even the clavicles move while you move your shoulder girdle around, your pectoral girdle, right? Now let's think about that with respect to clavicular injury. What do you guys think would happen if someone broke their clavicle? How movable do you guys think their shoulder joint's going to be as a result? Well, they can move it, but it's going to be painful, right? It's going to be very painful because the clavicle moves with the shoulder. So just something to keep in mind. Now, at the acromial end, it's also a synovial joint, and you have ligaments that can support this and hold it in place. Now, the glenohumeral joint is basically your shoulder joint. It's where the humerus, the head of the humerus meets the glenoid cavity. It's a diarthrotic ball and socket joint, so it's freely movable and it's ball and socket, so it actually has many degrees of rotation and movement. It's supported by a fibrocartilaginous labrum. So there's actually a labrum that's made of fibrocartilage that actually holds the head of the humerus in place. You have other ligaments like coracoacromial, coracohumeral, glenohumeral. And these ligaments basically just support the shoulder joint, and they're named for what bones they attach to or what bony structures they attach to. The shoulder joint's also supported by rotator cuff muscles. These rotator cuff muscles include muscles that attach to your scapula, and they actually surround the head of the humerus, and they help hold that humerus in place. But the rotator cuff muscles are also involved with arm movement. So if you're abducting or adducting or flexing or extending or circumducting, that's using your rotator cuff muscles. So they don't only help support your shoulder joint, but they also allow your shoulder to move, right? So you find a lot of bursa in the shoulder joint too. What was the function of bursa? Protection. And what are bursa made of? Synovial membrane. And what do they protect against? Friction. So it makes sense. You have this joint. It's freely movable, your shoulder joint, right? You're moving it around. Okay, let's say if you're swimming. Okay, with one arm. And you keep moving this arm around. Well, what happens to the muscles that are nearby each other? What happens with the muscles and tendons or ligaments and muscle and skin and muscle or bone and muscle? Like what happens to all those tissues that could potentially rub up against each other? They're supported by bursa, and that bursa reduces friction between those tissues. There's a lot of bursa then inside of the shoulder joint, which is pretty cool. So all this blue material here is showing the bursa. You can see there's a lot of it. We have subacromial bursa here. We also have a tendon sheath around our deltoid ligament. Not deltoid, biceps brachii ligament. All of these here are some supporting ligaments. We call these the glenohumeral ligaments. And if you look at dissection here, in the cadaver dissection, this little ring of tissue here, this is the labrum. And the labrum is basically a little ring of fibrocartilage that helps hold the head of the humerus in place. So when you hear about people tearing their labrum, then they're more prone to dislocations, right? If the whole point of this labrum is to hold the ball in the socket, what if it's torn? And there's a little hole now in that labrum. Well, the ball can come out of its socket pretty easily, right? So with a torn labrum, then you're more prone to dislocations. Now, the most common types of dislocations occur posterior to anterior. Someone getting hit in the back, and it's pushing their shoulder forward. Okay. Now, the reason being is that there's not a whole lot supporting the anterior side of the humerus. However, getting hit in the front and going back is less likely to dislocate because there's bones back here, right? Like you got the acromion process that can actually help hold that shoulder joint in place. So if it's a posterior to anterior type of motion, that's most likely to cause dislocation. So you might wonder, well, what would that be like? Well, what if someone fell on their back, right? And they fall right here. Well, it can knock their shoulder out forwardly, right? What if they fall on their front and they fall on their shoulder anteriorly? Well, it's pushing it back. It's less likely to dislocate that way. You could break bones or something like that, exactly, or just tear tissues, exactly. And have you guys ever seen anybody dislocate a shoulder?
Yes.
Yeah.
It's
It looks painful.
It's gnarly.
Yeah, gnarly is a good word. In fact, one time I saw it happen was I was at a beach, and there's these big waves crashing on a shore. We call it beach break. And so people like to body surf beach break. They'll get up in the wave and like kind of ride it. But the thing is, it crashes right on the sand. It doesn't crash in water. It crashes on the sand. So what this means is if you actually get in the wrong part of the wave can smash you on the ground. Actually, by the way, President Obama does that. He body surfs because he grew up in Hawaii. Just like picture, you can Google him like President Obama body surfing. You can see him. It's like, see, that's pretty badass. So that's actually kind of cool. That's pretty cool. But where I saw this happen though before, you guys, this guy was body surfing. He went over the fall, so the wave crashed on the ground. He landed on his shoulder like back. It pushed it out, and his arm was just dangling there. And he's holding his arm up because it's just dangling. And he's screaming in pain. Luckily, someone knew what to do. So they ran up to him, and they basically circumduct his arm. They pulled it back, and it like that. They circumduct it, and it kind of popped it back in.
Does it still hurt after it's back in?
You know, from what I saw, his pain seemed to go away immediately. Like as soon as it popped back in, he's like, "Oh, thanks," and just kind of walked away.
Oh my god! It
Yeah.
depends on how long it's been out too. Like if it's been out for a while,
Yeah.
then it can be really painful.
Now, I think the pain would come later because of inflammation.
Right.
So after, yeah,
And then if
Yeah.
you wait a while too, trying to pop it back in it can pop back out.
Yeah.
After it's like had time to inflame.
yikes.
Grow.
So luckily we got a nice little labrum here, little ring of fibrocartilage that holds our head of our humerus in place. So looking at a different view here, you guys can see the labrum again. You got rotator cuff muscles and supporting ligaments as well. And it helps hold the head of the humerus on the scapula. However, the Glenohumeral joint is one of the most unstable joints in the body. Okay, that and the hip joint are two of the most unstable joints, which means they're also the most freely movable. So it's kind of interesting. So what about the elbow joint? Well, the elbow joint's made up of your basically your humerus and ulna. Okay, a little bit of radius too, not a lot of radius. In fact, it's where the ulna. Remember, the proximal end looks like a C, almost looks like a claw. With the olecranon process, the coronoid process, and the trochlear notch, and that sticks onto the humerus, and it kind of rocks back and forth, right, like a hinge. Okay, so if I'm flexing, extending, my ulna is basically just rocking anterior, posterior on that joint. That's the elbow joint. Okay, so it's a type of hinge joint. It's also a synovial joint though, because it's freely movable. It's highly movable, and it's supported by a lot of different supporting ligaments. Now, one thing that's important to note, you guys, is that ligaments attach bone to bone. Tendons attach muscle to bone. So if we say a radial collateral ligament, that means it's actually attaching the radius to the humerus, not like a muscle to the radius. Then if there's a muscle attaching to bone, that's a tendon. If we call it the ulnar collateral ligament, then that means it's attaching the ulna to the humerus. Okay. Now, this is what we see here, you guys. All these ligaments support the elbow joint and keep it in position. Now, you can tell it's also a synovial joint because it's got the joint cavity here. And one thing that's important to note too, you guys, is right by the medial epicondyle, next to the medial epicondyle and trochlea, there's a little notch here called the ulnar sulcus, or ulnar notch. And the ulnar sulcus is where your ulnar nerve runs by. And so if you bump your elbow, then you can bump that nerve because it's right next to it. And that's why they call it the funny bone, because if you bump your elbow, it could potentially excite that nerve, and it's not so funny. You know, it's only funny if you're like a sadist or something. Like you get pleasure out of other people's pain.
It's like a weird combination of pain and numbness.
Yeah, it's true.
It burns.
Like it hurts, but it doesn't.
Yeah, that's weird. Do you have a question? No? Okay.
Oh no.
Okay. That's all right. I thought I saw a hand up. Okay, so the radiocarpal joint or wrist joint, you guys, it's diarthrotic joint, and you find this at the radius and the carpal bones. In fact, most of your wrist joint is due to the radius. So remember the distal end of the radius was wide, and it can articulate with a lot of your carpals, including the scaphoid and lunate. The head of the ulna is part of the wrist joint, but it's a very minor part of that wrist joint. Okay. Now, the three proximal carpal bones that are involved with your wrist joint are the scaphoid, lunate, and triquetrum. And you can see that all these carpals are supported by a synovial membrane. So what's interesting is if you're moving your wrist joint around, those carpals are sliding against each other with a fluid-filled membrane between them, which is synovial membrane, this is one of those gliding types of joints because these bones just glide across the carpals. So it's pretty cool. By the way, what's missing in here? Marrow, because we're looking inside the bone. So you don't see yellow bone marrow. I don't know why that's removed. It's just something I noticed really quick. I don't know. So what about some joints of the lower limb? Well, we got the hip joint, knee joint, talocrural, and joints of the foot. So the hip joint is actually very similar to the shoulder joint. It's still a ball and socket. It's supported by a lot of supporting ligaments, they're named for what they attach to, like iliofemoral, ischiopubofemoral, and the ligament of the head of the femur, also called a round ligament. This ligament of the head of the femur is actually what attaches to fovea capitis on the head of the femur, and so it keeps that head of the femur in place. Now, looking at the structure of our hip joint, we see a lot of supporting ligaments here. So they basically help keep the femur in position. If you look inside of the joint, we see then here's that ligament of the head of the femur. It helps hold the femur in place. And that's basically, it's more stable than your shoulder joint. Now the knee joint is actually kind of interesting because it's basically where the distal end of your femur meets the proximal end of your tibia. And what's interesting is they kind of are shaped like little fists. So imagine your knee joint is like trying to stick two fists together, have that be movable, but also stable. So that way they just like kind of, break apart and then your leg falls away from the rest of your thigh. So how does that work? Well, we have menisci, and the menisci are little rings of fibrocartilage that help hold the bones in place. We also have other supporting ligaments like a patellar ligament, collateral ligaments, and cruciate ligaments. Now these collateral ligaments you find outside of the joint. The cruciate ligaments you actually find within the joint itself. And they're called the cruciate ligaments because they cross. So you have the anterior and posterior cruciate ligaments that cross within your knee joint. And what they do is they prevent anterior and posterior displacement of the knee. That way your knee doesn't wobble back and forth. That's what the cruciate ligaments do. So looking at structure of a knee joint, we see superficially we have quadriceps muscle here. The femur is deep to that. Here's the patella. We see this is the patellar tendon, which is what attaches your quadriceps muscles to the patella. We have the patellar ligament, which attaches your patella to the tibia. And within the knee joint itself, you got the cruciate ligaments that cross, going back and forth. There's some supporting bursa as well. And then on this next slide, we're looking deep inside the knee joint. We got the articular cartilage here on top of the bone. Here are the menisci. So this is the lateral meniscus. Here's the medial meniscus. How can we tell this is the lateral meniscus just based on the structure? Yeah, look where the fibula is at. Fibula is lateral on the leg. So if you've seen the fibula, that means that this is the lateral side. So it's the lateral meniscus, also called, lateral meniscus. This is the medial meniscus on this side. So these menisci help hold the bones in place. They're kind of structured like a donut. Like if you're what this reminds me of, you guys, is if you're going to go to like a water park and you get into one of those big old inner tubes and you plop your butt in that inner tube, you're in there pretty well, right? You're not just going to fall out of the inner tube very easily. Think of that like the bone is like a butt and the inner tube is like the menisci. Because the menisci are circular and they kind of hold the bone in place like your butt plopped in an inner tube, right? It's not going to move around very much. So what does this mean if someone gets a meniscal tear? Well, it means that their knee joint might be more unstable. It might kind of wobble in a particular direction depending on where the tear is. Now, inside of the knee joint, we have our cruciate ligaments. So you have anterior cruciate ligament, posterior cruciate ligament. And these cruciate ligaments basically prevent anterior and posterior displacement of the knee. So what this means is that if the cruciate ligaments tear, the knee might wobble to the front or to the back. So it's kind of interesting. And in fact, that's how they test for it, is if you suspect someone of having a cruciate ligament tear, they'll grab your knee, they grab the tibia, like the leg, and the femoral area, and they kind of try to move them against each other. Normally, there shouldn't be a lot of wiggle between your leg and thigh, right? Your knee joint should be pretty stable. It should be maybe slightly movable, not very movable. I'm not talking about like moving like a hinge. I mean like actually wobbling against each other, right? If those cruciate ligaments are torn, you might see a lot of give. In fact, this is why people wear like knee braces and stuff like that if they do have a cruciate ligament tear, because it helps hold their knee in position. Otherwise, if they didn't have that, their knee would kind of slip away from within itself, which sounds horrible. So that's like ACL and PCL, by the way. What about the collateral ligaments? Well, we have the medial collateral ligament and the lateral collateral ligament. The lateral collateral is also called the LCL. The medial collateral ligament is called the MCL. And so you guys are probably familiar with hearing about different tears like an ACL tear or an MCL tear. Now you know that the ACL means what? Anterior cruciate ligament. And what is it? What's the cruciate ligament's main role? Yeah, the cruciate ligaments prevent wobble or prevent the knee from moving anterior or posterior. Good. How about if someone tears their MCL, like their, what's that called? Medial collateral ligament. So if they tear this MCL, then what might happen to their knee joint then? Yeah, it might wobble side to side. You got it. So it's just amazing to me, you guys, that this all works. And it works pretty well as long as you treat your knees properly. So that to me is just pretty cool. Because think about it, like this is such it seems like a very inefficient type of joint. What about the ankle joint? Well, the ankle joint is also a hinge joint, and it's supported by different ligaments. We have deltoid, lateral, and tibiofibular ligaments. So what you see here then on the talocrural or ankle joint is it's supported by a lot of ligaments, and these ligaments essentially help hold your tibia and fibula to the talus as well as the calcaneus, and that's what you're standing on, right? So when you're standing, you're actually standing on and supported by this particular joint, which is holding the rest of your leg to your foot, which is pretty amazing. So if these ligaments are torn or injured, then you'll have difficulty standing. Now, and for the joints of the foot, you guys, they're basically named, but for what bones they're between, right? So what are the ankle bones called? Tarsals, right? And what about the foot bones? Metatarsals, right? So what do you guys think the joint is where the tarsals meet the metatarsals? The tarsal metatarsal joint. That makes sense, right? How about where the metatarsals meet the digits or phalanges? Yeah, metatarsophalangeal joint. How about between all of your digits, like between all the phalanx of your digits? Interphalangeal joints, aka IP joints. So interphalangeal. So they're basically just named for what they're between. So it's pretty straightforward. Again, like all these other joints, they're supported by a lot of ligaments, and they're synovial joints because they're freely movable. So what this slide shows here, you guys, is basically those joints. So what joint's this then? So here's the tarsals. There's the metatarsals. So the tarso-metatarsal joints. Here's the metatarsals phalanges. So then we have the metatarsophalangeal joints. And then between all your toes, interphalangeal joints. Now, what I would challenge you guys to do is next time you stub your toe or somebody else stubs your toe, think about what joint might be affected. If they say, I stubbed my toe, now my foot hurts. What part? Is it interphalangeal? Is it metatarsophalangeal? Is it tarso-metatarsal? Just something to consider. It's kind of cool.
Stub your toe, like more than likely it's interphalangeal.
Yeah, more likely it's interphalangeal. Exactly.
Because of